That's correct. Yes, what else? Platelets, will you check platelets? It will be what? Decrease, right? You want to rule out what? Coagulopathy, that is correct. The next one, we can also do a BUE and what? Brightening, right? Why we need BUE and brightening? No, electrolyte. To rule out what? Renal what? Dysfunction. Because chronic liver disease can predispose to what we call hepatorenal syndrome. Okay? So yes, the renal impairment will happen. Okay? The next one, we can do lipid profile. True or false? Because we want to rule out what? Hyperlipidemia. Didn't you say it's the last one? It says that's the last one, right? So we have to rule out what? Hyperlipidemia. Because at the last one, they are due to what? Hyperlipidemia, right? Yes. The next one, we can also do liver function test. Liver function test. And we know why. Because the liver that is getting impaired. For the liver function test, albumins. What happened to albumins? It will decrease. What happened to AST? Increase. What happened to ALT? It will increase. What happened to GGT? GGT. It is increasing alcoholics. Are you getting that? GGT will be increasing what? Alcoholics. What happened to alkaline phosphatase? It can also be what? Increasing. Okay? But these are the ones that we look at. Okay? So AST, what's another name for? What's the chemical name? The standard name for ALT, alanine amino transferase. Is what? I mean, that's the name. But if you are looking at the chemical structure, how does former name? They call it what? So ALT is also known as SGPT. AST is also known as what? XGOT. So the SGPT is serum glutamic pyruvic transaminase. Serum glutamic pyruvic transaminase. Okay? And we know alanine is on ALT is known as what? Alanine amino transferase. Okay? But formerly, it was named based on the chemical composition, which you call serum glutamic pyruvic transaminase. I hope you can write that. How do you write it? Yes. Okay, it's glutamic or glutamic. Okay. Then glutamic pyruvic transaminase. LGBT. When we come to SGOT, we have serum glutamate oxaloacetic transaminase. Okay. Alright, let's move on. The next. And that's why we can also do a clotting profile, right? Clotting profile. Clotting profile. What are we checking for? The INR or the prothrombin time? INR or what? Prothrombin time. INR or PT, prothrombin time. We can also check the serum glucose. Why are we checking serum glucose? Because usually when you have disease, hypoglycemia is, especially those who drink alcohol, okay? And even the liver disease, but those who drink alcohol will be more predisposed to what? Developing hypoglycemia. We will explain that very soon. So serum glucose is written. We're written that, right? Yes. We're written that. Okay. We can also do ascitic tap. Ascitic fluid tap. Ascitic fluid tap. What are we doing? What are we using for? For biochemistry, microbiology, and what? Cytology, yes. Ascites without. In the case, mostly in the case of what ascites. Okay. Now we cover it. Then we can also do an ultrasound scan, abdominal ultrasound scan. Why are we doing that? Fred? The size of the liver, whether it's reducing. Okay, so here you can use to, hepatomegaly. Okay, ascites, splenomegaly as well, right? We can also do a liver biopsy. When it comes to chronic liver disease or liver cirrhosis, the gold standard is what? Liver biopsy. Because the liver biopsy will help you to find the bridging fibrosis and what? The regeneration of noodle, that's correct. Regeneration. So the gold standard of investigation for chronic liver disease or liver cirrhosis will be what? Liver biopsy. Okay? Are we following? We can also do head CT scan. Why are we doing that? Kennedy? Yes, to rule out what? Subdural hematoma, especially in who? Yes, alcoholics. Because they are liable to fall without even knowing. Are we following? Yes. They can fall. There was a patient like that I've seen. He came, has been alcoholic for 20 years. And when he came, he was living abnormally. Initially, I was moving towards hepatic encephalopathy in what? An alcoholic liver disease. But I saw some sign around the head. I requested for a CT scan on the head. A CT scan, it came up and it was subdural hematoma. So for alcoholics, they can fall down without knowing. When they come, you ask them, they are not really oriented. No, but I'm not. It's always wise to be on there. You should always try to introspect so that you can get the diagnosis right again. Okay, then the other investigations that we can do will be towards what? Finding the underlying cause. Okay, so the investigation to identify etiology. Okay, identifying etiology. We can do hepatitis B and what? C. Screen or serology. Are we getting that? Are we following? Yeah. We can also check for what? Serum, ceruloplasmin. That would rule out what? Are we following? Wilson's disease. Okay. We can also do iron studies. Iron studies, what will be the, what are the constituents? That's one person, please. One person, not all of you. All of you will create a chaotic thing. Serum iron. Serum ferritin. Ferritin transferrin and what? Yes. That is correct. Can you give us what will happen to them? Yes, you want to rule out hemochromatosis. So hemochromatosis, you want to do iron studies. Now let me ask this question: why is iron so important in a woman's body? What chemical property of iron makes it so important? Because we know iron helps in the transport of electrons, true of course, and even the transport of oxygen, right? So you should know that iron, element iron, can easily accept electrons in an aerobic medium. Are you getting that? It means that iron can easily be what? Oxidized, such that its valency changes from what? 2+ to 3+. Are you getting that? So that makes iron very, very important. Even though excretion of iron is difficult, that is why it's installed in the liver. Follow me. Okay. Now you should also know that microbes also depend on iron for their metabolism. So sometimes if a patient is having infections and you are giving them iron out without treating the infection, you may be experiencing a more severe form of the infection because the microbes will now be feeding on the iron and proliferating faster than before. Alright. We can also check level serum, okay, alpha 1 antitrypsin levels, and we know why we are doing that. We can also check for serum autoantibodies. Why? Because of the autoimmune conditions. Are you following? For bacteria, we will have to do what? An ultrasound scan because it will help us to, ascites, hepatomegaly, and also to find, when we say bacteria, what happens here is that it rarely happens, okay? A rare occurring condition characterized by what? A thrombotic or non-thrombotic occlusion of what? Of what? Hepatic vein. When you say hepatic vein events, can you follow? Alright, that's fine. Let's move on, etc. Let's move on. Now we are almost done. Are you surprised? Yeah, not surprised. Let's go. Let's talk about the complications of what? Complications of chronic liver disease or liver cirrhosis. Complications. So the complications will group them into three. Okay. The first one we will say liver what? Failure. The second one we will say portal hypertension. And the last one we will say hepatocellular carcinoma. What's another name for hepatocellular carcinoma? Clifford, Rebecca, Rejoice, Kennedy, Craig. Yes, Nafisa. Primary liver cell carcinoma. That's correct. So primary liver cell carcinoma. You should remember this. You know why I asked that? Because this condition mimics, let me tell you for fact, the secret. It mimics amoebic liver abscess. Amoebic liver abscess, it mimics it. So if you go for an exam and they say patient is passing first to run these and all that, they will have paid on. And you are thinking that they ask for two differentials. Don't just write the amoebic liver abscess, add primary liver cell carcinoma. Hepatocellular carcinoma. They can also call it. Exactly. Alright, so for the liver failure, there are complications that fall there. So we can take them. Liver failure. We can think of coagulopathies. True or false? True or false? We can think of hypoglycemia. No, before that, we'll get there. We can also think of what? Hypoalbuminemia, because albumins will not be produced again. Okay? Hypoalbuminemia. Hypoalbuminemia. We can also think of hepatic encephalopathy. Hepatic encephalopathy. We'll come back and talk about some of them. Okay? We can also think of hypoglycemia. We can think of sepsis. Sepsis and like that, we can be focused on pneumonia, septicemia. We can also think of what? Spontaneous bacterial peritonitis. We'll talk about that very soon. Spontaneous SBB. Spontaneous bacterial peritonitis. Then, hepatorenal syndrome. Can also talk about the hepatopulmonary syndrome. Remember? Do you remember? Yes. Well, we said that they would have what we call lactimia. Was it here? Lactimia, remember? Yes. Lactimia, they would exhibit lactimia. And I also said that in these patients, they will have low level of oxygen saturation when they are what? When they are standing or sitting. How do you call that? Yes. We call it Peritonitis. People. Michael. Yes. Eh? No, orthodoxia. Octodioxia. Yes. Octodioxia. Octodioxia. Okay, then this is rare. It's not so common. Then we can also talk about hepatocardiac syndrome, which is also very rare. Hepatocardiac syndrome. Rare? It's rare. Hepatocardiac syndrome is rare. It's rare. Can we move on? Yes. Okay. So now let's talk about the complications under the general one. That's portal hypertension, the one that fall under portal hypertension. So for portal hypertension, we think of ascites. We can also think of splenomegaly. Then what Aziz was saying, that will be the portal systemic shunt. Portal systemic shunt. For portal systemic shunt, such as what? Aziz? Esophageal varices. And also caput medusa. Esophageal varices. Caput what? Medusa. Then we can also add excellent hemorrhoids. That's correct. Anorectal varices. Hemorrhoids. That's correct. Very good. Okay, now we are going to take some of them and comment on them. So we'll take the first one. This one, hepatic encephalopathy. So let's go on hepatic encephalopathy. Hepatic encephalopathy. After that, we'll comment briefly on hypoglycemia, spontaneous bacterial peritonitis, hepatorenal syndrome. Aside we commented on that. We will talk about esophageal varices. Then we'll move straight to the clinical scoring systems. Okay. After that, we'll talk about the factors that indicate bad prognosis. Then we'll look at the treatment, and that will be it. Encephalopathy. Now let's talk about the pathophysiology. Pathophysiology. So for the pathophysiology, we will say that as the liver fails, pathophysiology of hepatic encephalopathy. As the liver fails, because in chronic liver disease, the liver is no longer functioning as supposed to. And we said that hepatic encephalopathy falls under the broader complication called liver failing. And you can see the reference that we have made. Okay? So as the liver fails, nitrogenous waste products, such as ammonia. You know ammonia, right? NH3. Nitrogenous waste products such as ammonia build up in circulation. As the liver fails, nitrogenous waste products such as ammonia build up in circulation and passes into the brain, passes into the brain via the blood-brain barrier. That's the BBB, blood-brain barrier. And do you know why it's able to pass through the blood-brain barrier? Yes, anyone? Why is it able to pass through the blood-brain barrier? As this, because ammonia is what? Lipophilic, and the blood-brain barrier has a lot of what? Phospholipids in it. How do you get that? It has a lot of bilipid layer. It has a lipid layer in its what? Barrier. So you should know that like for like, if you are lipophilic, you can only dissolve through a lipophilic medium. If you are hydrophilic, you can only dissolve in water. So lipophilic, like for like. So it's able to percolate through the blood-brain barrier into the brain. Are you getting that? Yeah. So it passes into the brain by the blood-brain barrier. Okay? Where astrocytes clear heat. You know astrocytes, they are protective, they are like glial cells in the brain. They kind of die against what? Invading micro or foreign organisms. They kind of protect the brain against invasion by what? Microorganisms. They defend. Okay? They are like glial cells. Okay? So astrocytes, when they enter into the brain, astrocytes then tend to what? Clear them. Okay? So we'll say that the clearing involves the conversion of glutamate, that's glutamic acid in the brain. You know that glutamate is a neurotransmitter? You know? Glutamate, conversion of glutamate into glutamine. And you know why? Because ammonia. See, look at ammonia. If you look at ammonia, can you get NH2 from it? So if you add it to glutamic acid or glutamate, it can give you glutamine. Okay? This how you getting that? And that's in excess glutamine. Excess glutamine causes an osmotic imbalance. Excess glutamine causes an osmotic imbalance, resulting in a sheet of fluid into the cells at the brain cell, resulting in a sheet of fluid into the cells, leading to cerebral edema. Exactly. So as the nitrogenous vehicle that builds up, you should know that the liver, if having its integrity, is supposed to clear the ammonia by reacting with acid to form ammonia so that it is easily excreted, or to convert the ammonia, okay, by using the amino group, okay, by using the amino group of it into the synthesis of amino acids, useful product. But here lies the case, the liver has failed. What it has failed, the nitrogen, the ammonia tends to build up in circulation, and as it builds up in the circulation, it tends to move from a region of higher concentration to a region of lower concentration. And one of the sites will be the brain. And due to the fact that ammonia itself is lipophilic, it's able to dissolve through the blood-brain barrier, gets into the brain, where astrocytes clear it. How does the astrocyte do that? By making sure it converts glutamic acid or glutamate into a glutamine. And glutamine has a high osmotic potential. So it's able to what? Cause fluid drift from the vessels into what? The cells. Then the cells will start swelling. And when the brain cells are swelling, we call it what? Cerebral edema. The cerebral. Behind the cerebral cortex. Are we getting that?
Yes.
Are you following?
Yes.
Yes, go ahead. You get it? I didn't hear you. Alright. Please, let's move. Now let's look at the grades of hepatic encephalopathy. Yes, please.
I read from somewhere that glutamate is a new excitatory neurotransmitter.
Yes.
So with the depletion, it inhibits excitation in the brain.
What is an excitatory?
The glutamate.
Glutamate, yes.
So because it's being used up, it's inhibits.
Yes. So it will cause an inhibitory effect. Or there's another pathway too, but we don't normally talk so much about it, where they are going to have, once you have the ammonia get into the brain, okay, then what will happen is that it can enter into another cycle where it will lead to the production of what alpha ketoglutarate, and from chain to chain reaction, it will lead to the resultant production of gamma aminobutyric acid, which is a suppressor. So looking at glutamate is an excitatory. It's getting used up. Why? Because it's being converted from its active form to another form, which is glutamate. So at the end of the day, the reference level or the level of glutamate that will be left will become very small, giving way to what? Neuroinhibitory mediators to act, and that will give you what? A depression of what? Sensorial. Yes, and that will give you hepatic encephalopathy. Yeah. Now let's look at the grades. So the grades, we have grade 1. Grade 1, what are we going to see? Grade 1, we'll say that grade 1 there will be altered mood or behavior. Altered mood or behavior. You see, all of a sudden, they are frowning. They don't look happy as they used to. Or they are behaving some way. Then, the next one, they will have a reverse sleep pattern. Reverse sleep pattern. As you know, usually you sleep in the night and what? They are active during the day. But these patients will be sleeping during the day and at night they are up. Reverse sleep pattern. Is that clear? Alright, and the next one is to have what we call constructional dyspraxia. You have what we call constructional dyspraxia. Constructional dyspraxia. Contractional dyspraxia, how do you see that? You ask the patient, you give a pen and a paper to the patient. Yeah, okay, please draw a 5-pointed star. 1, 2, 3, 4, 5. You ask them to draw this. Okay, you do the pen and paper. Please. Do you have a draw the patient has we came and I gave him the pen and paper. This is what he was asking. That was what he was able to do. It was so difficult for him. Okay. So if you're having constructional dyspraxia, inability to draw a 5-pointed star, and you know that they are stage 1. But always remember that if they come with that and you see a particular parameter in the higher stage, you choose the higher stage. For example, we have a patient having contractional dyspraxia and they are having what? Incoherent speech, or they are incoherent. That will be stage grade 3. You will not sleep to grade 1. Are you getting that? And another thing here is you have a poor arithmetic form. What do we mean by that? We just give them simple maths. 2 plus 2, 22. They are able to add numbers, they are able to do subtraction, they are able to do basic arithmetics. Okay? Then they will not have no liver flap or asterisis. Liver flap is the same as flapping tremor. How do you ever see that? This is how you end it. You have the patient stretch forth the arm and what? Clock the wrist. Okay? They should have closed the eyes as well. They should spread from the arm. Close the eyes and clock the arm. Clock the wrist. When you do that, involuntarily, you are going to be seeing what? A flap. Have you noticed that? As if a bird is flapping its wings. Okay? They will be doing it unruly, like involuntarily. Exactly. That's what we call flapping pheromone. It's more evident. It's evident in what? Coming back to liver cells. Exactly. But then here, in grade 1, you will not have what? Liver flap or flapping pheromone or hysteresis. We also call it hysteresis. Exactly. Exactly. Can we move on? Can I clean? Can I clean this?
Yes.
Grade 2. For grade 2, they will have increasing drowsiness or lethargy. There will be confusion, right? They will also have slurred speech. Slurred speech. You know what slurred speech is? Some of you know how to slur. You have slurred speech. How are you, Brian? How are you, Brian? You are not able to. The speech has been joined together. The words are joined together. Slur speech. Slur speech. Then we also have here, we have a change in personality. This one, please, this one you don't find it from the patient. How dare you find it from the patient? How are you going to know? You ask a relative or somebody who, know the patient very well, who has accompanied the doctor to tell if there has been a change in the personality of the person, or inappropriate behavior. Inappropriate behavior. Then the last one, plus or minus liver flap or hysteresis. So liver flap may or may not be present. Is that clear? Liver flap may or may not be present. So you have increasing confusion, yes, go ahead. Increasing drowsiness or mental, yes.
So from what we were saying before, if the patient has the altered mood, reverse sleep pattern,
yes,
and confusion,
yes,
you now grade it as grade 2.
Excellent, grade 2, yes. Please read that. Okay, please connect me. Connect me. Connect me, please. Yes. Let's look at the grade 3. So for the grade 3, you have what? An incoherent speech. They will be incoherent. When they are speaking, their speech is incoherent. They are incoherent. They will be restless. And also they will have what? They will be stupor. There will be stupor. And here, you will see that here, liver flap is always present. Liver flap here with no plus or minus. It will always be present. Okay? Please, are we clear on that? Yes. Are we clear? Alright. Then we move on in grade 4. There will be what? Comatose. There will be coma. So grade 4 of hepatic encephalopathy is what? Coma. Is that clear? Is that clear? Okay, let's look at how we can manage hepatic encephalopathy treatment. Treatment. So for the treatment here, we would admit the patient, would give IV 1 liter of 5% dextrose, plus papriness 1 and 2, 8 hourly. Papriness, what is papriness? 1 and 2. Okay, when they add it to the feed, you see that the food become yellow. If you go to the hospital, they are giving IV fluid to the patient, you see that it's yellow, you know that it added papriness. And papriness contains vitamins. It has vitamin B1, B2, B3, B6, and vitamin what? C. Exactly. It has B1, B2, B3, B6, and what? C. Those are the constraints of what? Happiness 1 and 2. Is that there? Then the next thing is what? Syrup lactulose. 30 to 50 mils, 8 hourly. Why have we given syrup lactulose? Now let's look at the mechanism of action. We will put it as inside. Mechanism of action of what? Lactulose. So the first one is lactulose. Lactulose is degraded into short fatty chain acids. Lactulose is degraded into short fatty chain acids. That is lactic acid. That is lactic acid. It's degraded into what? Short fatty chain acids. That is what? Lactic acid by the gut flora. The gut flora. By the gut flora. The lactic acid hydrolyzes in water. The lactic acid hydrolyzes in water, giving off hydrogen ions. The lactic acid hydrolyzes in water, giving off hydrogen ions, which binds to ammonia, to form ammonium ions, which binds to ammonia to form ammonium ions. Are you getting that? The ammonium ions are what? Polar. They are hydrophilic. They are polar. They are soluble in water. So which binds to what? Ammonia to form ammonium ions, which are water soluble. Ammonium ions, which are water soluble. Which are water soluble, and hence readily excreted. The second mechanism. The hydrogen ions degraded by the lactic acid. The hydrogen ions degraded by the lactic acid decreases the pH of the gas, making it an acidic medium. Which kills the nitrogen producing gut flora. Since we understand that, it means that the gut flora does not like acid. Wherever acid is, the acid denatures the proteins within their structure, killing them. Are we getting that? And if you do that, it means that nitrogen producing as ammonia will not be produced again. Hence, you are reducing the hepatic encephalopathy and you preventing any chance of worsening of the condition. Are we getting that? Then the third one is lactulose. Lactulose is an osmotic laxative. Lactulose is an osmotic laxative. Thereby causes fluid sheet. Into the gut lumen into the gut lumen and facilitates peristalsis. We said that lactose is an osmotic laxative, okay, thereby causing the sheet of fluid, okay, let's put it this way, thereby causing the sheet of fluid containing the ammonium ions. Because in the first one we said that the H plus will bind to ammonia to form ammonium ions, and we said that they are water soluble. Therefore, these ammonium ions will be contained in that fluid. Will be contained in that fluid that will be shifted into the gut lumen. So lactose is an osmotic laxative, thereby what? Causing the sheet of fluid containing the ammonium ions into the gut lumen and facilitating peristalsis. Lactose is an osmotic laxative, thereby causing the sheet of fluid containing the ammonium ions, because they are water soluble, Na4 plus, they are water soluble, containing the ammonium ions, okay, into the gut lumen and facilitating peristalsis, leading to the excretion of what? The fluid. Leading to the excretion of the fluid. The net effect of the three mechanisms that we said is what? A reduction in the level of what? Circulating ammonia and the number of nitrogen producing gut flora. Is that clear? The net effect is a reduction in the level of circulating ammonia and the number of nitrogen forming or producing gut flora. Is that clear? Is that clear? You have not responded, you know?
Yes.
Please read that. The net effect is a reduction in the level of circulating ammonia and the number of nitrogen producing gut flora. In fact, alright, the next one is, what are we going to give? We are going to give what we call oral rifaximin. Oral rifaximin. Please don't forget. Oral rifaximin. Let me tell you the secret. Oral rifaximin is the what? Antibiotic of choice in hepatic encephalopathy. Please don't get interested. Oral rifaximin is the antibiotic of choice in what? Hepatic encephalopathy. Which one of the following is the antibiotic of choice in hepatic encephalopathy? A. Ciprofloxacin. A. Ciprofloxacin. B. Erythromycin. C. Piperacillin tazobactam. D. Rifaximin. And E. Rifampicin. What we have to use, Michael? Rifaximin. Okay. So you should know that rifaximin is what? An oral, non-absorbable antibiotic which reduces the number of nitrogen forming gut bacteria. Oral rifaximin is an oral non-absorbable antibiotic which reduces the number of what? Nitrogen forming gut bacteria. The dosage that is used is what? 550 milligram 12 hourly. Okay? Is that clear? Is that clear?
Yes, sir.
Thank you very much. Alright. So this is how to handle hepatic encephalopathy. Is that clear?
Yes.
Alright. Let's comment on the hypoglycemia. That's hepatic encephalopathy. Let's comment on the next complication, that hypoglycemia. That one we are just going to explain why it happens in chronic liver disease, especially in alcoholics. Hypoglycemia. You should know that hypoglycemia is what? More common in chronic and is more common in alcoholic liver disease. Alcoholic, chronic alcoholic liver disease. The alcoholic liver disease more. Why? Let's explain. So let's explain that. So we say that hypoglycemia in alcoholics, okay? It's more common in alcoholics, more. It's more in alcoholics. Okay? Now let's explain that. We say that alcohol is oxidized into an alkanal. So we put here alkanal. So alcohol, we are talking about alkanal here. Alkanal. Alcohol, we mean alkanal. You know alcohol already, alkanal. It's oxidized into what? An alkanal. That is alkanal. Alkanal. It's alkanal, which is an alcohol. It's oxidized into what? An alkanal. That is alkanal by the enzyme alcohol dehydrogenase. By the enzyme alcohol dehydrogenase. By the enzyme alcohol dehydrogenase. And you should know this. This is what we say oxidation and what we say reduction. And when we are looking at the parameters. Okay? The parameters, we can talk about oxygen, we can talk about hydrogen, we can talk about electrons. Are we getting that? For oxidation, we are adding oxygen. For oxidation, we are removing hydrogen. For oxidation, we are removing an electron. For reduction, we are removing oxygen. For reduction, we are adding hydrogen. For reduction, we are what? We are adding what? Electron. Is that clear? Please, are you following? So if we are removing dehydrogenase, what are you removing? Hydrogen. So what are you doing? You are what? Oxidizing. That's why you are saying that alcohol is oxidized into an alkanal. That is ethanol. This is an alcohol is oxidized into an alkanal by what? The enzyme alcohol dehydrogenase. So in that case, we will say ethanol going into what? Ethanol. Here we are going to have alcohol dehydrogenase. And you ask yourself, what's the chemical formula? Ethanol is C2H5OH. Okay, C2H5OH. Look at what's going to happen. 2 molecules of hydrogen is going to be removed from this. Are you following?
Yes, sir.
Are we getting that?
Yes.
So if you remove the 2 molecules, look at what's going to happen. So it's like this. Alcohol is like this. CH3, CH2OH. This alcohol. Now you are going to remove 2 molecules. You remove one from here, you remove one from here. Okay, so if you remove, what are you going to have? You are going to have CH3, CH, double bond. It's going to be like this, double bond. Then you have O. And you should know that carbon is what? Tetravalent. You should have 4 bonds. 1, 2, 3, 4. Are you getting that? So if you are removing 2 hydrogens, what are you going to get? You are going to have C2H4O. Are you getting that? If you look at this, this is C2H6O, meaning that for any alcohol or ethanol that you have, alkanol, the chemical compound, their general formula will be what? CnH3nO. Are you following? Because if N is equal to 2 will go here. 3 by 2 will give you what? 6. Are you getting that? But if you come to alkanal, the formula will become CnH2nO. Are you following? Are you getting that? So at the end of the day, how many hydrogens have we lost? 2. And if you are removing hydrogen from a compound, what are you doing to it? You are oxidizing it. You understand? So now, if this happens, you can put it like this. So you are going to have CH3, CH2OH. Now going to what? CH3, CH double bond O. So you are going to have C2H6O going to C2H4O. So what is going to happen is that when this reaction is taking place, electrons will have to be transported. Have you getting that? So you ask yourself, the hydrogen that is removed, where is it going? Where is it going? Where is it going? So this is how it's going to look like. You are going to have CH3, CH2O, or let's use the name directly. So this will become ethanol, okay? Ethanol plus NADH. Not NADH. N become ethanol plus NAD plus, okay? Because there are two, so you are removing H2 and you are going to be adding to this. This is a transporter, okay? So at the end of the day, what are you going to have? You are going to have ethanol. So here we have alcohol dehydrogenase. Then we are going to have, at the end of the day, the H2 has been removed from ethanol. It becomes ethanol. Okay? It becomes ethanol. Then you are going to have this. If we add 2 molecules, means we are supposed to put 2 there. Then the resultant effect will be what? 2NADH. Let me see, you are having 2 molecules added here. Are we following?
Yes.
Are we getting that?
Yes.
So in that, did you get that?
Yes.
At the end of it, nicotinamide adenine dinucleotide becomes converted into a reduced nicotinamide adenine dinucleotide. Why we say reduced? Because hydrogen has been added onto it. Is that clear? Are we getting that?
Yes.
Are we getting that?
Yeah.
Please read that.
Yes, sir.
Okay. Let's move on. I like your response. I believe that when questions are right, when it's a good response, it's conversation. Alright, let's move on. This every move. Did you get the picture?
Yes.
Did you get the picture?
Yes.
This is biochemistry, chemistry. On display. Organic chemistry. Organic chemistry. Okay. Alright, let's move on. So, we said alcohol is oxidized into alkanol by the enzyme alcohol dehydrogenase. Okay, and you can see the reaction below. This results, the reaction results in the production of excess NADH. NADH stands for nicotinamide adenine dinucleotide. Okay, those of you are confused. Nucleotide, if they are confused, nucleotide. NADH. Okay, NADH is what? NAD is nicotinamide adenine dinucleotide. But if you add H to it, it becomes reduced nicotinamide adenine dinucleotide. Is that clear? Yes.
This reaction results
In the production of excess NADH. The NADH stands for reduced nicotinamide adenine dinucleotide. Is that clear? Is that clear?
Yes.
So the next thing, the excess NADH, facilitates the convection of pyruvate and oxaloacetate. You know, when you are going to the Krebs cycle, you have these things. Okay. They facilitate the conversion of what? Pyruvate and oxaloacetate into lactic acid and malate, respectively. So the excess NADH facilitates the conversion of pyruvate and oxaloacetate into lactic acid and malate, respectively. Are you getting that? This depletes the stores of pyruvate. This depletes the stores of what? Pyruvate and oxaloacetate, which are considered as precursors for gluconeogenesis. So it tells you that the precursor for gluconeogenesis will be what? Pyruvate and what? Oxaloacetate. So this depletes the stores of pyruvate and oxaloacetate, which are considered as what? Precursors of gluconeogenesis. The resultant effect is what? Hypoglycemia. Is that clear? Is that clear? Is that clear?
Yes.
Okay. So that's for that. The next complication, let me look at the complications that we've written so far. No, let's go to the result again. Let's go to spontaneous bacterial peritonitis. We'll talk about pathogenic pathogens.
Hypoglycemia, the liver with the glycogen storage in the liver as well.
Well, if you look at the liver as well, yes, we'll talk about that. The reduced storage, the reduced source of glycogen. Yes.
Lastly, the another source for the gluconeogenesis is the fat.
Yes.
So,
But you should know that, you see, the way the Krebs cycle works. If you look at the Krebs cycle, what do you need? You may need, okay, if you look at the Krebs cycle, when we are talking about decay, we will look at that. Where we are going to be having beta oxidation of fatty acids. And if that is happening excessively, NADPH will go high. And if we have NAD, that is going to be NADPH, which is a natural transporter. It will suppress the Krebs cycle. It will suppress, okay, pyruvate, what we call it? Pyruvate carboxylase. It will rather activate pyruvate carboxylase and be what? Suppressing the Krebs cycle. I think that. So instead of the fat going to produce energy, where it will be converted to glucose, that place will be shattered. It will be shattered. I think that. Then in liver disease, what we are looking at is that the precursors for gluconeogenesis, in this case pyruvate and oxaloacetate, will be shattered quickly to reach those stages. And if they reach there, it means that they will become unavailable for any gluconeogenesis to take place. So the next one, spontaneous bacterial peritonitis. Spontaneous bacterial peritonitis. So for this one, it means that there has been an infection where of the what? The peritoneal fluid, the ascitic fluid. Okay. So in this case, the microorganisms usually involved. Culprits. We can think of one, E. coli, Escherichia coli. We can also think of Klebsiella, and we can also think of what? Streptococci. Okay? These are the bacteria involved in what? Spontaneous bacterial peritonitis. Okay? For the diagnosis, you will do what? Ascitic fluid tap. And should you do the ascitic fluid tap? Yes, go ahead. Yes. More than 250 per what? Millimeter cube, okay? Of what? Polymorphonuclear leukocyte. In that case, we are looking at what? The neutrophils. That's the neutrophils. It's what? Diagnostic of spontaneous bacterial peritonitis. So if you do an ascitic tap and you are finding more than what? 250 per millimeter cube. If you don't like a millimeter cube, you can use microliter in place. Okay? Are we following? You can use microliter in place. Okay? So 250, greater than 250 per millimeter cube or microliter of polymorphonuclear leukocyte. In that case, we are looking at what? Neutrophils. It is what? Diagnostic of spontaneous bacterial peritonitis. Is that clear? Treatment. A drug of choice? Yes. insulin. What is the dosage? 4.5 gram 8 hourly. Okay? 4.5 gram 8 hourly. Okay? So the drug of choice should be what? Piperacillin, taxobactam. Okay. The dose maintained of 4.5 gram 8 hourly. Exactly. As a prophylactic drug, we could use what? Ciprofloxacin. For what? Prophylaxis. That's if there is no spontaneous bacterial peritonitis yet. And you want to guide against it. You could use ciprofloxacin. Is that clear? Is that clear?
Yes.
Okay, the next one. Which one is the next one? Hepatic renal syndrome. Let's talk about that quickly. From there, we'll talk about the portal hypertension, some of the complications there. Then we'll look at the clinical scoring systems, then the treatment.